Hello everyone. Now we are going to continue about the abnormalities of some shape of placenta. We in detail we are going to see afterwards also, but just it is this is in short. So it is what is it is the biscoid placenta or bipartite horseshoe sort of it. So if we say in this diagram, see the structure. So this is the part of the placenta. This is also part. This is also the part of the placenta, and from where here the umbilical cord arises. So, when villi persists on the entire surface of the chorionic sac, a thin layer of placenta it attaches to a large area of the uterus, and it is membranous placenta. So it is called as a membranous placenta. Then, say these are the abnormal varieties of placenta. From here also the umbilical cord arises. From here also the umbilical cord arises. This is the abnormality what we are saying it. This is battledore placenta where umbilical cord arises from the margin. So that is battledore. This is filamentous because this filamentous continues at the this side. So this is filamentous placenta. Then there is a circumvallate placenta. This circumvallate placenta, rounded structure, which is not normally present. And this is subcentuarata, that is some accessory lobe which is present. So that is subcentuarata lobe. So that is some abnormalities of the placenta. So in this diagram, what we are saying this is battledore placenta. What is it like a door? How it is opening? So this is umbilical cord, and which is attached at the umbilical attachment of the umbilical cord to the margin of the placenta. So this is the placenta, and how actually this looks like. So this is chorionic vessels between the amnion and the smooth chorion. So this is the part smooth chorion, this amnion lining the chorion and covering the fetal surface of the placenta. This is the margin of the placenta, and this one is the umbilical cord. This is filamentous attachment of the umbilical cord. What we say this one is basic structure. This is the placenta. This one is amnion, and this is a cord which is present. And umbilical vessels running under cover of the amnion to reach the placenta. In battledore, this umbilical cord starts from here in battledore, but when in filamentous, it is started at some distance, which is present for the arising of the umbilical cord. So umbilical cord attached to the amnion at some distance away from the placenta. That is filamentous cord. And this is placenta subcentuarata. That is something, this is the main placenta and some separate piece of placenta, accessory tissue, placental tissue at some distance from the placenta. So branches of the umbilical arteries and accompanying veins running under the amnion to reach a separate piece of placental tissue. So this is umbilical cord. That is placenta subcentuarata. So this is another diagram. This is the filamentous one. This is circummarginata. This is circumvallata. This is two lobes are present. That is called as a bilobe. It's an accessory lobe, subcensuarata lobe. And this is called as a margin. That is battledore or marginal insertion of umbilical cord. And depending upon the implantation, how much it is. So it is the accreta, increta, and the percreta. That is what I already know it. This one diagrams. This is the normal one. Accreta. It goes this one. It goes deeper into the middle layer. Accreta, increta, and this is the covering the peripheral layer. That is percreta. Then how this is the what we are saying. This is the embryo. What is this one is embryo. This one what is in this lavender color. It is the chorion, and this black it is the internal. See, that fluid is present for protection and prevention of desiccation. And this is the allantois yolk cell. This one is the yolk cell, and this one is the yolk cell, and this one is umbilical cord. Whatever the structure, it is yolk cell. And this one is the placenta, that is fetal portion of the placenta. And this is maternal portion of the placenta. So these are the extra embryonic membranes. So this is in reptile and this was in mammal. How the difference? This one is more in reptile and bird. See, what we have seen, this is viscera, that is nothing but the inner layer of the uterus during the pregnancy. That is inner layer in non-pregnant, it is not that much of thick. It is called as the endometrium. But after pregnancy, it is called as a decidua, and it is the best layer, that is called as a layer. Decidua, it is called as having 3 layers, 2 to 4 layers. That is decidua basalis. And this is thorium transversum. This one is the umbilical cord. Thorium, amnion. Placenta, whatever the fluid which is present inside, it is the amniotic fluid. And these are the layers. Thorium, amnion. And the fetus which is present inside of it. So what is the basic placental function? So what is the basic, as what I have already explained, it is transfer of nutrients and waste products between the mother and fetus, that is respiratory function, excretory function, nutritive function, and it produces or metabolizes the hormone and enzymes necessary to maintain the pregnancy. So that is the basic function of it. And it acts as a barrier function and the immunological function. So how it is one by one. So transfer function, what it transfers. So whatever the nutrients which are required are transferred to the fetus via umbilical cord, and transport, it is facilitated by the close approximation of maternal and fetal vascular system. And where it takes place, that is, it takes place in the placenta. And it is important to recognize that there normally is no mixing of fetal and maternal blood within the placenta, that is transferred. And what is transferred? That is the respiratory function and excretory function. So what is the transport? That is what is the oxygen, that is input of O2 and the removal of the CO2, which takes place by simple diffusion method. And the oxygen supply to fetus rate, it is about 5 ml per kg per minute. And this achieved with some flow of 165 to 330 ml per minute. And in short, you can remember that whatever the transport of oxygen and CO2, whatever requirement of input, that is oxygen, and CO2 is expelled out. And excretory function, that is, it has to remove the waste products from the body. Which waste products it has to remove? That is blood urea, means it has to remove the urea, uric acid, creatinine, are excreted to maternal blood by simple diffusion. Because these are the waste products. So this is the transported in that, partially consumed, metabolized, and the non-transported fat. Then nutritive function. So glucose is what is required for the development of the embryo. It is the glucose which is required, and it is the major energy substrate which is provided to the placenta and the fetus. So it is transported across the placenta by facilitating diffusion via hexose transporters. And although the fetus receives a large amount of intact glucose, a large amount is oxidized within the placenta to lactate, which is used for the fetal energy production. So how it is used in the fetus. Amino acid concentrations in fetal blood are higher than in maternal blood, and amino acids are therefore transported to the fetus by active transport. So lipids gets that is TG and FS directly transported from mother to fetus in early pregnancy, but afterwards they require, but afterwards synthesized in the fetus in the latter pregnancy. And thus fetal fat has got dual origin. That is two origins for the fetal fat. Dual means two. And water and electrolytes, Na, K plus, Cl minus. That is by simple diffusion, Ca, pH, ion by active transport. That is normal. That is Na plus, Na, K plus. That is what we are doing. And barrier function. So that's a protective barrier to the fetus against some noxious agents which are present in the blood. So these are not transported to the fetus so that the fetus gets protection from it. So that is one. And high NW is more than 500 deltas. Then immunological function. Yes, it acts as an immunological issue. The fetus and placenta contain paternally determined antigens foreign to the mother. In spite of this, no evidence of graft rejection probably. So fibrinoid and sialomucin coating of protoblast may suppress the protoplastic antigen. Placental hormones, that is steroids, HCG, estrogen, progesterone, have got weak immunosuppressive effect, may be responsible for producing sialomucin. So it is an immunological function. So whatever this method gives, it is a layer with when intervenes between the pseudobasalis, that is the basic layer of the deciduum, that is inner layer of the uterus, and cytoplasm probably inactivates the antigenic property of tissue. There is a little HLA and blood group antigens on the propoblast surface. And so antigenic stimulus is poor in this. So production of blocked antibodies by mother which protects from the rejection. And but obviously what we have known that, so it acts as an endocrine also. Hormones secreted internally. Hormones, any organic chemical that is secreted by a gland into circulatory system and is transported to some target organ. And the target may be either peripheral tissue such as the muscle or other gland or brain maybe. But in this, which one is, it is the fetal, placental and maternal compartments for an integrated hormonal unit. The fetoplacental maternal unit creates the endocrine environment and that maintains and drives the process of pregnancy and the prenatal development. What is meaning of prenatal? That is before antenatal development. So which are these hormones? So first what we know that it is the HCG. What is meaning of HCG? It is the human chorionic gonadotropin. Where we see it when it is in the urine pregnancy test. If it is present, then the UPT is going to be positive. So human chorionic somatotropin or placental, that is second name it is called as HPM, that is the human placental lactogen. And not this much, but other hormones are also released, that is the chorionic adrenocorticotropin, chorionic thyrotropin, then relaxin, then PTH, RP, HGHV, that or you can remember the estrogen and the progesterone. And other hypothalamic like releasing hormone, that is GnRH, CRH, CKRH, GHRH. Then placental peptide hormones, that is neuropeptide Y, inhibin and activin A and P. That is to understand this, one should know that is the major hormones involved in is HCG and progesterone and estrogen. And human chorionic somatotropin, that is placental lactogen, that is HPL. Then how the FPM compartments work together to produce the steroid hormones and the transfer of hormones between the FPM compartment. That is fetal placenta. And whatever the half-life, human HCG, that is pregnancy hormone, glycoprotein, its half-life, it is about 24 hours of HCG. And what is its length? Its levels peak at some 60 to 70 days, then remain at a low plateau for the rest of pregnancy. So how much it is level, how much high? It is up at 60 to 70 days. Then slowly later when HCG hormones decrease, low level. Then placental GNRs have control on the HCG. And what is the function of it? It is the rescue and the maintenance of function of corpus luteum. So that is the main function of it. Second, it prevents the degeneration of corpus luteum. It stimulates the corpus luteum to secrete E plus E, which in turn stimulates continual growth of endometrium. So whatever the growth which takes place in the next during the pregnancy, it depends upon this HCG hormone. Then again, it stimulates the Leydig cells of male fetus to produce the testosterone. That is in the male development of this means for the production of testosterone in conjunction with fetal pituitary gonadotropins. Thus, indirectly it involved in the development of external genital of the genital in the penis. And it suppresses the maternal immune function and reduces possibility of fetus immunorejection. So that is the function of HCG that what we have seen in here.